Today, I'm going to be talking to you about some updates in infectious diseases literature.
You have to click on it again to use this. There you go.
I am not financially benefiting from this presentation any more than my impressive residency salary. And these are the objectives of my talk today. As a kind of heads up, I'm going to be using a lot of PICO tables. If you haven't seen those before, they're just kind of a way of summarizing studies and breaking them down into like study population, the intervention being assessed, the comparator group, and the overall outcome. So moving on to the new infectious disease literature to come out that in this case is not COVID related because that definition of new is very different. We're going to be talking about extended spectrum beta-lactamases, which is actually going to be kind of the star of the show. I'm sure a lot of you already kind of know what study I'm going to be talking about. We'll then move on to gram-negative bacteremia and then kind of do a quick wrap up on some updates in community-acquired pneumonia. So first of all, I want to talk about extended spectrum beta-lactamase infections. And we're going to actually start with a patient case. So I hope everyone got into Pull Everywhere efficiently because you got like 30 seconds. Anyway, so imagine there's a 34-year-old female. She's coming to UC Davis from an outside hospital. She's got a past medical history of recurrent UTIs. She has fever, dysuria, flank pain, hypotension, elevated white blood cell counts. At the outside hospital yesterday, she got a dose of ceftriaxone. She's here, and she brought with her a urine culture that's positive for ESBL E. coli. The gram blood cultures at both the outside hospital and here, nothing's grown yet. What do you feel like is an appropriate antibiotic to start? And if that's a lot of words, there's a severe pyelonephritis with an ESBL. What do you want to start? Okay, I'm going to say that's long enough to answer. And now we come to the tricky part where we try to see your answers. No. Oh. 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 Wonderful.
Read all those emails. Ooh.
People thought nothing. Okay.
I don't think you'll catch it.
It's not letting us answer.
Yes, important step. Let's try that now. Is that working for people?
Yes.
Okay, I'm gonna give you 10 seconds. That's the answer. Okay, so the majority of people thought meropenem. A couple people thought peptazo. Surprisingly, more people thought ceftriaxone than cefepime. Okay, we will. We will come back to this later. All right, so bacteria form resistances to antibiotics in lots of different ways. One of the most infamous ways is developing enzymes that break down the antibiotics. And this is something we classically associate with beta-lactamases. Beta-lactams get their names from the beta-lactam ring that's in the center of all of them. It's here indicated in green, and it's really important because it allows the beta-lactams to mimic cell wall precursors that then trick the penicillin binding proteins into targeting the antibiotic and then subsequently inhibiting synthesis. However, if beta-lactamases become part of the equation, they can break open that beta-lactam ring, leaving the antibiotic ruined and useless. Beta-lactams come in a whole variety of classes, and those are determined by the adjacent structures to that beta-lactam ring. The structures kind of determine the overall stability of the beta-lactam ring and the resistance to beta-lactamases, which is at least partially responsible to the different spectrums of activity we see for these different beta-lactams. Similarly, beta-lactamases also come in a variety of shapes, sizes, and according to this slide, colors that also have a different affinity for breaking open different beta-lactams. Let's just talk for now about extended spectrum beta-lactamases. They get their name from their ability to break open extended spectrum cephalosporins, which we now just call third generation cephalosporins. And they're often plasmid-mediated, which just means that they're perpetually expressed in the organism and not inducible like AMP-C, which you may have heard from other people. The primary culprits found in possession of ESBLs are generally E. coli, pneumoniae, and Klebsiella. There's some other bacteria that are all gram-negative that can also support this enzyme, but much less frequently. There's also slightly different variants of ESBL, and those nuances are very difficult to discern. The real important thing is that CTXM is by far and away the most common ESBL we see now. So ESBLs are really effective at breaking open penicillins, cephalosporins, monobactams, but then when it comes to the carbapenem is actually probably a little bit too stable for them, so the ESBL is kind of left huffing and puffing, and that's why when we talk about treating these ESBL infections, carbapenems are kind of the first line that we talk about. However, beta-lactams don't have to fight these beta-lactamases on their own, and they can call on their trusty sidekicks, beta-lactamase inhibitors. Beta-lactamase inhibitors are beta-lactam mimics so for here, we see the beta-lactam ampicillin. And we see with it its trusty partner in crime, the very familiar looking sulbactam. Essentially, when the beta-lactamase shows up, it's tricked into targeting the beta-lactamase inhibitor, where it becomes permanently bound and inhibited. Beta-lactamase inhibitors are generally pretty effective against most ESBLs, but can be variably effective against some other beta-lactamases like AMP-C. They also tend to lack individual antimicrobial activity on their own, but when they're combined with the beta-lactam, they become a valuable tool in fighting these antimicrobial resistances. So one of the most famous of the beta-lactamase inhibitor pairs is piperacillin-tazobactam. Tazobactam is an inhibitor that restores activity to the penicillin piperacillin against a variety of beta-lactamases, including ESBL. Like I mentioned before, tazobactam does struggle against the AMP-C beta-lactamases. So, since tazobactam has efficacy against ESBLs, it raised the possibility of pip-tazo as a carbapenem-sparing alternative in the management of ESBL infections. For many years, there was an ongoing debate about pip-tazo's niche in treating ESBL bacteremias. There was a lot of different multi-center retrospective studies that looked at pip-tazo in these ESBL bacteremias, and they came up with pretty conflicting results. It ranged from an increase in mortality with pip-tazo to no difference in mortality and a significant drop in MDRO infections. However, with that data, a lot of clinicians still felt that pip-tazo had a good role in ESBL bacteremia and certain patient populations, specifically those with non-severe illness, urinary source infections, and particularly low pip-tazo MICs. And this debate led us to the Marino trial in 2018. This is probably one of the most talked about ID trials to come out in the past several years. And so I'm sure a lot of you already kind of know the gist of what this study determined, but I think there's some value to be gained from diving into the details. This was a multi-center randomized non-inferiority study in patients with ESBL bacteremia. Patients could either receive piperacillin-tazobactam 4.5 grams every 6 hours or meropenem 1 gram every 8 hours for 4 to 14 days as definitive therapy. The primary outcome was all-cause mortality at 30 days post-randomization with a non-inferiority margin of 5%. The study's definition of ESBL was phenotypic resistance to ceftriaxone, but not to pip-tazo or meropenem. The patients also had to be randomized to one of their study treatment arms within 72 hours of their initial positive blood culture. The exclusion criteria were pretty minimal, essentially boiling down to patients treated without curative intent and those with polymicrobial bacteremias or need for additional antibiotics beyond the study drug. The study also stratified enrollment by pathogen, urinary source, and PIP score, which is just a metric for clinical severity, really targeting in on those niches that we talked about earlier that clinicians like to use pip-tazo in. So here we can see the general structure of the treatment arms. Essentially, patients could receive any antibiotic at all during their empiric therapy phase, but within 72 hours, they had to be randomized to the study arms of meropenem or piperacillin-tazobactam. At that point, they had to receive the study drug for at least 4 days. Starting on day 5 post-randomization, they could continue their treatment or move on to step-down therapy. And step-down therapy was basically any susceptible antibiotic that aided discharge. and that could include the very popular once-daily ertapenem, which is a carbapenem. So investigators assumed a mortality of around 10%, targeted a non-inferiority margin of 5%, leading to a plan to recruit about 450 patients to reach power. They did some interim analysis and actually noticed a widening gap in mortality between the two treatment arms, and eventually it was determined that it was unlikely Peptazo was going to reach non-inferiority, and so they concluded with early termination. If we look at the baseline characteristics of what they ended with after termination, you can see that the two treatment groups are actually pretty fairly matched. There was about 7% of both arms in the ICU. There was a pretty hefty amount of immunocompromised patients included in the study, with Peptazo maybe taking the trend towards the larger share. And then by far and away, the vast majority of these ESBL bacteremias were caused by E. coli, which isn't at all surprising based on what we know about the prevalence of them in the ESBL. On top of that, with the E. coli, it's not surprising that the majority of these infections were coming from the urinary tract, with intra-abdominal infections coming in at a pretty distant second place. This is the descriptions of the antibiotics that the two arms received. It was, again, pretty similar in terms of the duration of study drug, which is around 7 days, and the overall duration of antibiotics, which is around 13 days. The real thing I want to draw your attention to is the amount of carbapenems that both arms got in the empiric phase and in the step-down phase. And I think that'll actually be a little bit easier to see if we go back to this treatment arm and really focus in on the piperacillin tazobactam arm. To describe what you're seeing here, the different colors indicate which antibiotics the patients got at each phase of treatment. So you can look at this. Blue is a beta-lactamase inhibitor, which is usually piperacillin tazobactam, while red is a carbapenem. And you'll notice that in this piperacillin tazobactam arm, 13.8% of patients got their empiric therapy with carbapenem, and 20.7% of them got step-down therapy with carbapenem. So the real takeaway should be, for our supposed not carbapenem arm, that's a lot of carbapenem use. At this point, you should be looking and thinking, this seems pretty biased towards generating non-inferiority for Peptazo. But then we go and we look at the actual results of the study, and it's really not too hot for Peptazo. In the primary outcome, which was mortality at 30 days, Peptazo failed to reach non-inferiority against meropenem, with a difference of 12.3% to 3.7%. That's a number needed to harm of 12, with the harm being your patient died. And even when we broke it up by severity, it was still a difference that persisted. Even when we looked at urinary tract infections versus not urinary source infections, the difference wasn't as big, but Peptazo still failed to achieve non-inferiority. In fact, across all the various different subgroup analyses that these authors did, every single one of them failed to find Peptazo non-inferior to meropenem. When you look at the Kaplan-Meier failure curves, it's pretty clear, it looks pretty bad. Peptazo separates out early and progressively gets worse over time. So the conclusion of the study was that definitive treatment for Peptazo in ESBL bacteremia is not non-inferior to meropenem, and the authors concluded that you should not be using Peptazo in this indication. Now, any study this big and practice changing is going to come with a lot of criticisms, and I think those are also worth addressing real fast. So the Marino trial really discredited those niches we talked about, particularly patients who weren't that sick and patients with urinary sources, but it didn't really address that third niche I mentioned, was what about when the Peptazo MIC is super low? In fact, the breakpoint they used was less than or equal to 16, which is the standard breakpoint, and clinicians have been arguing that that's too high for ESBLs. In addition, they also use test strips for susceptibilities, and I could go into tons of argument over the nuances to this, but what you need to know is that actually it's broth microdilution that's the preferred method of determining susceptibility. So to address this, the Marino trial authors actually went back and redid post-hoc analysis of all the specimens they collected, doing the susceptibilities again with broth microdilution. And they published this results, which again looks pretty bad for Peptazo. This is the Peptazo arm mortality sorted by piperacillin tazobactam susceptibilities. You'll see here there's actually no correlation between the actual MIC and the mortality. And in fact, even when the Peptazo MIC is super low, all the way down to 1, there's still incredibly high mortality of 30%. Additionally, another argument was that the ESBLs were confirmed phenotypically and not through genotyping. When they went back and looked at the genotypes, they only found ESBL genes in about 85% of them. The concern being that we might be actually including other beta-lactamases, and we know that Peptazo doesn't do so hot in those. some people will argue that this was bad inclusion criteria, but you can also make the argument that co-expression of these other beta-lactamases isn't too uncommon in ESBLs, and maybe this is why piptazo failed to reach a non-inferiority. I'm sure a lot of you already kind of know a little bit about the biofire system we use at UC Davis. As a quick sneak peek, the micro department is currently working on upgrading us to biofire BCID2, which has a whole lot of new identifications it can spot, here indicated by the asterisk. The relevant part here, we will be able to identify ESBL CTXM genes going forward. It means we'll find out about these ESBL bacteremias much faster. So the final comment I want to make on the Marino trial is that it actually couldn't really assess the impact of piptazo as empiric therapy just by trial design. If you go back and look at it, about 26% of the carbapenem arm got piptazo as their empiric therapy, but only like 3.7% of them died. So this might be like a similar situation to vancomycin and beta-lactams for MSA bacteremia. We have a lot of really good data that shows that beta-lactams have a mortality benefit over vancomycin as definitive therapy in MSA bacteremia, but there's also a lot of studies that show that there's no real benefit to just starting with vancomycin and then optimizing when you get your susceptibilities back. We don't start every single person who has GPCs in their blood on vanc plus cefazolin, so you can make an argument that maybe not everyone with a whiff of ESBL risk factors needs to be started on carbapenem. So is this the end of piperacillin tazobactam as definitive therapy in ESBL infections for now? Well, not quite. There's actually been a lot of RCTs done, prospective RCTs, looking at piperacillin tazobactam's use in lower urinary tract infections, and it's been pretty effective. It generally shows very similar efficacy rates to carbapenems. And more recently, Seema Sharara et al. Actually published a study, Is piperacillin tazobactam effective for the treatment of pyelonephritis caused by ESBL organisms? This was a multi-center study, multi-center retrospective propensity score weighted cohort study looking at patients with ESBL urine cultures who were also diagnosed with pyelonephritis, which was defined as pyuria, fever, dysuria, and then one of emesis rigors, hypotension, and flank pain. Patients could either receive piperacillin tazobactam or carbapenem that had to be started within 48 hours and continued for at least 72 hours, with a primary outcome of recurrent cystitis or pyelonephritis with that organism within the next 30 days, and secondary outcomes of clinical resolution, 30-day mortality, and 30-day CRE acquisition. So similar to the Marino trial, patients could step down after those 72 hours of study drug, and were included. Here's the exclusion criteria. One notable difference from kind of the structure of the Marino trial, they didn't allow treatment crossover. If you got piperacillin tazobactam for 72 hours and then your step-down therapy was ertapenem, you were excluded and you weren't involved in the analysis. They also didn't allow patients with bacteremia because we already know those patients do worse on piptazo. An interesting exclusion criteria was that you weren't allowed to study unless you had blood cultures drawn within 48 hours of your urine culture. And that's important because we don't give blood cultures on every patient who has a UTI. We only really draw them on patients where we're concerned about potentially progressing to a bacteremia. So by having this as an exclusion criteria, the study is already very biased towards sick or high-risk patients. It also was a propensity score weighted cohort analysis. As a quick summary of what that means, they basically use a multivariable model to try and normalize out the differences between the treatment arm characteristics. Here's the different covariates they used. It was pretty broad and trying to account for a lot of different things. And these were the baseline characteristics in the cohort, both before and after the propensity scoring. The one thing I want to point out is that there were a lot of ICU admissions in both arms, and this was even before the propensity score got involved. And then we look at the results. The primary outcome of recurrent UTIs within 30 days was actually pretty similar between the two arms and non-inferior for the piperacillin tazobactam arm. And if you look at the secondary outcomes, it's pretty favorable for piptazo as well, non-inferior in terms of day 7 clinical resolution and 30-day mortality. Also to note, it wasn't statistically significant, but there was a trend towards lower CRE acquisition in the piptazo arm, which also makes sense. So the positives to this study was that it was multi-center, it grabbed patients with definitive ESBL through genotyping, and they really focused in on high-risk and severely ill patients. that we tend to be actually usually more conservative with. There's some big limitations. Obviously, it was a retrospective study. The propensity scores are always kind of tricky. They're good at normalizing out these confounders that you know, but they can sometimes make worse the confounders you don't know. Additionally, they didn't allow treatment crossover. So theoretically, if you got pip/tazo, failed therapy, and got salvage therapy with a carbapenem, you wouldn't be included. So we criticized Marino for allowing treatment crossover, and now we're going to criticize this study for not allowing treatment crossover because we're just never happy. In conclusion, we definitely need a good prospective study in this area, but at this point, it's definitely reasonable to think that pip/tazo could be a suitable alternative to carbapenems when treating pyelonephritis caused by ESBL, but not bacteremia. So now that I've gone on about ESBLs, here's kind of the key points. If you have a confirmed ESBL bacteremia, pip/tazo is not going to cut it. You need to start a carbapenem. And we have BioFire 2 coming, which means we'll find this out much faster. The impact of pip/tazo as empiric therapy, before we find out what the susceptibilities are, is more vague and needs to be elucidated more. Finally, piperacillin tazobactam might still have a role in ESBL infections if there is no bacteremia, and most of this data is currently in urinary tract infections. So going back to our patient case with our severe pyelonephritis with ESBL but no bacteremia, ceftraxone and cefepime definitely aren't going to cut it. The ESBL is going to tear those apart very quickly. Meropenem is a classically right answer whenever you're talking about ESBLs, but you could make an argument that we don't have bacteremia, so pip/tazo could be used. All right, so now that I've spent 20-something minutes talking about gram-negatives and bacteremia, I want to talk about gram-negatives and bacteremia. Let's try to do another patient case, let's see if I can double this computers again. Okay, so we have that patient that we were just talking about, so hopefully this isn't much reading, but while we're sitting here arguing back and forth, debating whether or not we want to use our pip/tazo, we find out, oh no, that BioFire came back and it is ESBL E. coli in the blood. Well, we quickly start meropenem because that's what we learned you should be doing. The fever and hypotension resolve within 48 hours. Patient feels much better, is now walking around the floor, is asking when she can get out of here. We get out on day 5 of appropriate antibiotics, and the team asks, how long do we got to treat this thing? I think this should be active. So should it be 5 days, in which case we'll just stop everything now, 7 days, 10 days, or 14 days? Okay, it looks like most people think that we should be doing 7 days, with a fair amount of people saying 10 and 14, and a few very brave people saying that they just want to stop their antibiotics now. All right. So gram-negative bacteremias cause a lot of, again, we'll come back to that answer later after we look at some data. Gram-negative bacteremias are a major cause of mortality and morbidity in the hospital. Obviously, as a group, the gram-negative bacteria themselves are very diverse, and the different infections that they cause are variable as well. Traditional dogma has always been you need to treat these gram-negative bacteremias with 10 to 14 days of intravenous antibiotics, and we saw that in the Marino trial where the patients all got about like 13 days of antibiotics. However, there's been a big push recently in infectious diseases literature to start testing shorter and shorter durations as we hone in on just how many days of antibiotics we need to treat these infections. And that led to the study 7 versus 14 days of antibiotic therapy for uncomplicated gram-negative bacteremia. And now that it's on a giant screen, I really hate that they used the word 7 and the number 14, but we will quickly move away from that. Anyway, so this was a study, a prospective randomized multi-center study that looked at aerobic gram-negative bacteremia in patients who had gotten 7 days of appropriate antibiotics and were afebrile and hemodynamically stable for 48 hours prior to day 7. They could either get a short course of 7 days or a long course of 14 days of antibiotics, with a primary outcome of a 90-day composite outcome of all-cause mortality, clinical failure, readmission, or extended hospital stay. The secondary outcomes were just all the individual outcomes of that composite score. So, as I mentioned, gram-negative bacteremias are a very diverse group of infections. This study wanted to focus on uncomplicated infections, and that meant that they excluded all deep-seated or uncontrolled infections. I'm talking endocarditis, osteomyelitis, meningitis, undrained abscesses, things that by their very nature require a longer duration of antibiotics. Similarly, if the patient had persistently positive blood cultures, that just means you probably have one of those above infections, and those were also excluded. Patients with severely immunosuppressive conditions were excluded, but those were actually only defined as patients with HIV, stem cell transplant, or persistent neutropenia. And again, as I mentioned before, if patients had to be clinically stable, hemodynamically stable, and afebrile for at least 48 hours prior to randomization at day 7. So let's look at another study treatment timeline. They started with gram-negative bacteremias with appropriate source control who had gotten 7 days of appropriate antibiotics. And again, the past 48 hours, they had to be hemodynamically stable and afebrile. Post-randomization, they either got the 7-day course, which meant just stop all your antibiotics now, or the 14-day course, which meant they got another week of antibiotics. And here are kind of the highlights from the baseline characteristics. The population was fairly old with like a Charlson comorbidity score of 2, so that's not too bad. They did have a fair amount of immunosuppression, about a quarter in both arms. And once again, by far and away, this study was heavily carried by E. coli-caused bacteremias. It's about 60% of both arms. Pseudomonas caused less than 10% of the bacteremias in both arms. Additionally, once again, the majority of these infections were caused by urinary tract infections, with about 65% of both arms, followed again by intra-abdominal infections, and then distantly primary bacteremia. For those of you scratching your head, primary bacteremia just means that I don't know where this came from. The primary outcome, which again was the composite outcome of all-cause mortality, clinical failure, readmission, or extended hospital stay, showed that the short arm was non-inferior to the long arm. And when they broke down all those individual components across the board, the 7-day course was non-inferior to the longer course. Additionally, when they looked at time to return to baseline activity, the shorter course actually was significantly faster in returning than the longer course. And the idea is generally that 7 more days of antibiotics means 7 more days of hospital or SNF, and those kind of things add up in terms of how long it takes you to recover. So there's a lot to like about this study. It's a randomized controlled trial with pretty broad and relevant inclusion criteria, and then relevant patient outcomes of mortality and relapsing bacteremia. The downside, it had a composite outcome, which is never really our favorite thing to see because it can kind of magnify differences between treatment arms. But this is a non-inferiority study, so the fact that they didn't find non-inferiority in a composite outcome is probably a good thing. Additionally, this was very heavily weighted to infections caused by urinary source infections, particularly those by non-lactose fermenters or E. coli. Patients were also randomized at day 7, which really biased patients towards patients who survived that long. And what that just tells you is you maybe can't predict a 7-day course on day 1, but if it's now day 7 and patients been walking around for a couple days, you can start talking about stopping antibiotics. So their conclusion was, in patients with uncomplicated gram-negative bacteremias who are stable and afebrile for 48 hours, 7 days is non-inferior to 14 days. In a very similar vein, last month there was another study published by Von Deck et al. Of effect of C-reactive protein-guided antibiotic treatment duration, 7-day treatment or 14-day treatment on 30-day clinical failure rate in patients with uncomplicated gram-negative bacteremia. I really missed the one-word trial names. This was also a multi-center prospective non-inferiority study looking at gram-negative bacteremias. But this time they had to be clinically improved for at least 24 hours prior to randomization at day 5. Additionally, from the other study, this study sprouted a whole new arm, being CRP-guided antibiotic duration. CRP, or C-reactive protein, is a marker for systemic inflammation, and based on sepsis studies, the authors determined that a 75% drop from peak was indicative that the infection was resolved and that you could therefore safely stop antibiotics. As its comparators, it had the fixed 7-day duration and the fixed 14-day duration, with a primary outcome of clinical failure at 30 days, with a non-inferiority margin of 10%. The exclusion criteria are very similar to the YAHA study. Specifically, complicated infections without source control were once again excluded, along with severely immunosuppressive conditions. This time, patients again had to be clinically stable for 24 hours prior to randomization at day 5. And so this treatment timeline should look super familiar again, in that you have uncomplicated gram-negative bacteremias who got 5 days of antibiotics and were afebrile and hemodynamically stable for 24 hours. They either got the CRP guided duration, which meant your antibiotics continued until your CRP dropped to less than 75% lower than your peak, or you got a fixed 7-day course, which meant 2 more days, or a fixed 14-day course, which meant 9 more days. And the patient characteristics looked very similar to all the other studies we've talked about so far. The source of bacteremia was far and away urinary sourced, and the causative agents was far and away E. coli. Notably, about 7% of them were those scary ESBLs, which is kind of interesting. But if we now dive deeper and see what was the actual antibiotic durations of those CRP-guided arms, we see that like the majority of patients actually got like 7 days anyway. A few got less than 7 days, but also a few really dwindled on to like the 16, 17 points. And then there's that guy who like haunts my stewardship dreams. And the results of the study showed good clinical responses in all the different treatment arms, around like 95% regardless of your treatment course. The authors used like a one-sided 95% confidence interval for determining non-inferiority, but basically they found that the difference between the CRP guided and 7-day against the 14-day was statistically not different. Additionally, the 30-day all-cause mortality was not statistically significant, but trended actually up in the CRP guided and 7-day arms versus the 14-day arm. So in conclusion, the study determined that if you have an uncomplicated gram-negative bacteremia, using CRP guided durations or a fixed 7-day duration is non-inferior to the 14-day duration and 30-day clinical failure, and kind of raise the question that maybe these idea of CRP guided durations might be the way of the future. So now that we've talked about a couple of studies in gram-negative bacteremia, they all seem to have a very consistent, similar outcome. If you're talking about a patient with uncomplicated gram-negative bacteremia with a good source control, and they clinically recover in a couple of days and are feeling fine, you probably only need about 7 days of antibiotics. Save the 14 days of antibiotics for your sicker patients. So we go back to that patient case. This patient had an ESBL bacteremia. She got appropriate antibiotics with meropenem. She clinically resolved in 2 days and got 5 days of antibiotics. According to both of those studies, she's feeling well, and provided that she still feels well for the next 2 days, she probably only needs like 7 days. All right, so now as we get more close to the end of the study, I just want to do some quick updates on community-acquired pneumonia. We will talk now again about a different patient case. Now imagine you have a 74-year-old male who's brought in from his nursing home. The staff reports that a couple days ago he had an aspiration event, and now he's been febrile with concern for infection. His past medical history is hypertension, hyperlipidemia, type 2 diabetes, but pretty well controlled, and no hospitalizations within the past year. He's reporting he has fever and shortness of breath, but his respiratory rates are 22. He has a little bit of leukocytosis, his serum creatinine is normal. They do a chest x-ray and see a lower lobe opacity that's suggestive of pneumonia. The intern wants to start antibiotics. Which one do you feel comfortable with him starting? And this is a select all that apply. And again, a lot of words, non-severe aspiration pneumonia in a nursing home, what do you want to do? Okay, third time's the charm. All right, it seems very fluid. The majority of responders seem to think they're happy with ceftriaxone. About 29% wants to start vancomycin. I'm assuming no one who said ceftriaxone also said cefepime simultaneously. And then about 6% think that we need to have metronidazole because there was aspiration involved. All right, let's talk about some more studies and then come back to these three. So, very recently, just last year, which feels not that recently, the ATS and IDSA got together and published the 2019 updated guidelines for community-acquired pneumonia. And this was long overdue, replacing the very outdated 2007 community-acquired pneumonia guidelines. So one of the biggest topics of discussion in this new guideline addressed the HCAP term, which stands for Healthcare-Associated Pneumonia. In the 2005 HAP-VAP guidelines, it was introduced as a term, but now in the 2019 guidelines, they abandoned it. So what is HCAP? It essentially is meant to define patients who are in the community environment but are at a higher risk of acquiring multi-drug resistant organisms. And when it first came out, it was defined as residents in a nursing home or like an LTAC, hospitalization for over 2 days in the last 90 days, home infusion recipients, chronic dialysis, home wound care, or the very easy to identify family member with known antibiotic-resistant pathogen. All these patients, according to old guidelines, were instructed to, when they came and presented with their pneumonia, to be treated as if they had a HAP or a VAP. But in that very long 12 years between guidelines, a lot of studies were done that kind of questioned the reasoning behind this strategy. In 2007, Rockberg et al. Published the study, Association of Guideline-Based Antimicrobial Therapy and Outcomes in HCAP. Essentially, this was a retrospective study looking at a multi-center cohort of community-acquired pneumonias who technically fit the definition of HCAP. Particularly, they were included, they had dialysis, admission from a nursing facility, or discharge from a hospital recently. They labeled patients as either receiving guideline-based therapy, which meant appropriate coverage of MRSA and Pseudomonas, or non-guideline-based therapy, which meant any deviation from that at all. They looked and compared these groups in in-hospital mortality and a slew of other secondary outcomes. And when they looked at this, they actually saw that guideline-based therapy was utilized more heavily in patients with severe pneumonia and those with multiple comorbidities, which isn't at all surprising because these are the kind of patients we're very conservative in. And when they went and they compared between the two arms in terms of mortality, they noticed that the guideline-based therapy was actually associated with an increase in mortality. And that was even when they attempted to account for things in terms of comorbidities and disease. And yes, this difference isn't because they killed people. It's probably because these patients who get guideline-based therapy do have higher severity of illness and are at more risk for these mortalities. So that was definitely a confounder. But the takeaway was that not using guideline-based therapy wasn't associated with any kind of mortality difference, and it wasn't associated with the risk of treatment failure. So the takeaway of the study was that maybe blanket treating all these HCAPs as if they were a HAP is probably not necessary, and it might be a little bit better to approach them individually with their own risk factors and severity of illness. Now, the specific guidance on when you should actually cover MRSA or Pseudomonas was much more sparse in these guidelines. If you have non-severe pneumonia, the only real heavily influenced risk factor was if you were previously found to have a respiratory isolation of your MRSA or Pseudomonas. In patients with severe pneumonia, the, again, major recommendations of when to add MRSA or Pseudomonal coverage was, again, prior isolation of those pathogens or recent hospitalization in which the patient got parenteral antibiotics. The definition for them of severe pneumonia is listed here. It was basically patients who either needed vasopressors or mechanical ventilation, or 3 of these minor criteria, which are generally just markers for possible sepsis. The final risk factor they mentioned was really just punting it down to the local level and saying start it based on your locally validated risk factors, which most places probably don't have. As a kind of general rule that's been seen, MRSA is seen a little bit more frequently in those 2 major risk factors, also seen more often in hemodialysis, patients with IV drug use, and patients who have some kind of empyema or abscess going on. Pseudomonas is seen more frequently in cystic fibrosis, immunosuppression, bronchiectasis, and recurrent COPD exacerbations, but none of these risk factors are super well validated, particularly at our level. And so UC Davis is hoping to address this with an update in the community-acquired pneumonia guidelines we have here, Those were on their way, and then COVID happened, so they're stalled, but they will probably come out in the next year, and hopefully we'll have more clear guidance on when you should start. In the meantime, the guidelines said you could continue to just keep empirically treating these patients like you did before, and then just rapidly de-escalate within 48 hours if you don't find any of the pathogens. And for anyone who remembers getting one of these tips earlier in the year, MRSA surveillance cultures are a great way to start empirically and then quickly de-escalate. These MRSA surveillance nasal swabs have been very well validated in very large studies with consistent results across different publications, and essentially are useful tools in ruling out MRSA pneumonia. If you've got a patient with pneumonia and they have a negative MRSA nasal swab, then that has a negative predictive value of over 95%. So that means in these patients, you can pretty confidently come in and say we should stop the vancomycin and save the patient's kidneys. The other major update I want to talk about the community-acquired pneumonia guidelines is aspiration pneumonia. Aspiration is just when someone has fluid from their mouth or gastric contents that come up and end up going down the wrong tube and ending up in the lung. It's generally associated with like anatomic defects or vomiting or altered level of consciousness, and essentially the fluid enters your alveoli, causing inflammation and irritation. It's more classically associated with like a pneumonitis, but it can cause a pneumonia. In this guideline, the guideline update, they had previously suggested in the 2007 guidelines that if you have an aspiration pneumonia, you should empirically start anaerobic coverage. In the updated guidelines in 2019, they did an about face and said, never mind, don't empirically cover anaerobes unless there's an empyema or abscess. And it's good to look at why are we saying this. So aspiration, it turns out, is a very common event, or more specifically, microaspirations. And as we've done more and more studies, we've kind of actually figured out that aspiration pneumonia might not actually be different than regular pneumonia, because all pneumonias are probably the result of at least microaspirations. The initial idea of anaerobes being an issue were actually based on very, very old microbiology studies back in like the 70s and 80s. And what they had initially done is they had these aspiration pneumonia patients. They would go in and do a transtracheal sampling, and they would find anaerobes. However, a lot of these studies use transtracheal sampling, which isn't great, and they also looked at patients later in their treatment course. So what we think might have happened is that the pathogen was already gone, and now we're just picking up on these anaerobic colonizations of the trachea as opposed to the real pathogens. More recent studies that instead of focusing on aspiration pneumonia have focused on aspiration events have actually been more convincingly saying that anaerobes don't really drive the show, and if we catch them, they're more passengers than true pathogens. Additionally, a lot of the antibiotics that we use for anaerobic coverage, particularly my nemesis clindamycin, are associated with significant increases in C. diff infections. So if we don't think anaerobic coverage helps, and we do know that it causes C. diff, then the reasoning to not include it in aspiration pneumonia makes a lot of sense. However, cases of abscesses and empyemas are still very different, and so in those situations, you should still include your anaerobic coverage. So, as a quick summary, HCAP is gone. You shouldn't use broad empiric coverage on all of them, but maybe look at the patient specifically and pick your risk factors. And you don't need to do anaerobic coverage for aspiration pneumonia unless you have a lung abscess or empyema. So we go back to our patient, and we say he does have aspiration pneumonia. He hasn't been to a hospital in the last year. So ceftriaxone definitely, I think, based on what you have here, a good answer. If you wanted to dig deeper in this chart and try and find a risk factor, you might find something for vancomycin or cefepime. You also could just start broad and then de-escalate after 48 hours. The big wrong answer is he aspirated, and that doesn't mean he needs metronidazole. So this is the point at which I tell you you didn't need to be here for a whole hour. You just need to look at this one slide. The summary, what I hope you take home from listening to me talk. Piperacillin-tazobactam isn't good enough for ESBL bacteremia, but maybe good enough for ESBL infections that don't have bacteremia. If a patient has uncomplicated gram-negative bacteremia and they clinically look amazing, maybe stop at 7 days. Finally, HCAP is dead. Pick your risk factors. Don't just treat everyone the same. And you don't need to do anaerobic coverage unless there's an empyema or abscess. These were some studies I was going to talk about that are future, but we do not have time for that. So these are references. Do you guys have any questions?
I'm in the chat.
There are some in the chat, but how do I see them?
On top, hover over.
Yeah, chat.
Who could? Oh, okay. Alrighty. What's the difference between defining ESBLs phenotypically and genotypically? Kind of, without running back there, if it's genotypically, you know that it's an ESBL versus technically just the way Marino did it, which was ceftriaxone resistance, but peptide susceptibility. Technically, things like AMP-C, which isn't an ESBL, can cause that if it's become stably derepressed, and therefore you don't necessarily know you're talking about ESBLs. You could be talking about other beta-lactamases, and that's important because peptide has variable effect depending on the epitope, on the beta-lactamase. Phenotypically, MIC sixth in the generation cephalosporins are resistant. Oh. Wait, no, this is the question's already been answered. Is it possible? That's a good question. It wasn't a prospective study, so they didn't actually choose who got blood cultures. It was a retrospective. The question is, the Sherrard et al. Study, which was the ESBL pilot study, if they potentially got those blood cultures to make sure there wasn't a bacteremia. That study was a retrospective study, so they didn't control what happened to the patients. And so by having that as an exclusion criteria, they basically, all those patients who came in with ESBL cystitis and no one was concerned about bacteremia, those got excluded. Okay, are there questions in the room? If not, then I somehow sprinted and made up the difference. And we finished on time, I think. If there are questions that you think of later, feel free to email me at tjginjtee@ucdavis.edu, and I will try to respond to those as soon as possible.
So just an FYI, if you guys do attend in person, then Lulu or me will be keeping track of names. But if you guys attend online, I'll be sending out that Google form. It's just like a one-click thing, and then I can link your name. It's just all nice stuff.
When they close, they're like, we're out. It's super frustrating because you're like, it's still like the green one.
I know.